I'm going to introduce our next speaker. She is Dr. Karen Lascelles, is a mental health nurse and senior lecturer at Oxford Brookes University. She has specialized in the areas of suicide and self-harm for over a decade, working with patients, family members, and carers, and clinicians. Her doctoral research investigated the experiences and needs of family members of adults at risk of suicide, and current research interests include suicide among nurses, impact of deaths of patients by suicide on clinicians, and the role of religion and spirituality in suicide bereavement. She has been involved in national work on suicide clusters, suicide, self-harm, psychosocial assessment, and NICE guidelines development. Welcome. Thank you.
Hi, thank you very much for having me and for inviting me today. I'm here today not as a scholar on the concept of empathy, but really as a jobbing clinician and educator that strives to be an empathic practitioner and to develop others to become the same. So what I'm hoping to do is my main practice area is in relation to suicide and self-harm. So that's the area I'm going to focus on. And I want to sort of think a bit about the value of empathizing with the suicidal wish, but also the challenges in doing that. And sort of not, just sort of consider the concepts of effective and cognitive empathy in line with that, and empathic validation. Given my doctoral study was around families and carers, I also want to sort of think beyond the patient and thinking about empathizing with the family, with people who struggle, maintaining safety and living with someone who's suicidal at home. And then I want to think about empathic disconnection and the realities of that and how we deal with it. And so for me, the principles of self-empathy, self-compassion and self-reflection are helpful to do that. And I'm going to be brave and bear all and share a couple of clinical experiences to try and illustrate some of what I'm talking about. So firstly, empathy with the suicidal wish. The proponents of this will say that actually the only way we can ever work effectively with suicidal patients is if we take a phenomenological perspective and understand the lived experience by sitting with and putting up, imagining the suicidal desire of the patient with this, understanding why suicide seems to be the only solution. It doesn't mean endorsing suicide, and it does mean maintaining a prevention practice. We're doing so with the bravery, really, of seeing suicide as an option and sitting with the reality that that's somebody's wanting at the time. Excuse me. It's underpinned by an understanding of the concept of psychological pain, also known as psychache, that in relation to suicide, Schneidman developed some years ago and really led these advocates of empathizing with a suicidal wish to think about that when psychological pain becomes unbearable, that's when suicide becomes a very real option. And to truly empathize, we need to work with that. Excuse me. So empathizing with the suicidal wish draws on all of the dimensions of empathy that we've already talked about today. Pompili here talks about empathizing with the suicidal wish and really draws on effective empathy and the neuroimaging research that, he says, we talked about pain and empathy, and he talks about the human misery and psychological pain that we can see. We can see psychological pain in the brain, but also that we need to effectively resonate with that. And that will activate our hot motor system and therefore facial expressions that will mimic those of the person with us and convey a real sense of empathy. And he says if we do that, then that will be the most powerful thing to unlock the suicidal mind, because it will open and there will be that sort of sense of resonance, and the patient will feel heard, and we can move forward to understand what's going on. But where the arrow comes down, if we're not doing that, or if we're kind of hindered then by our fear, and he talks about fear of contagion, and I think he's talking about empathic contagion or emotional contagion and empathic distress. to do with suicide risk. Are we going to just become really bogged down by the distress? For me, it's more than that. It's also fear of responsibility, it's fear of blame, it's fear of litigation. Fear is the biggest barrier to empathizing with the suicidal wish. And that fear then can really stymie any empathic sort of resonance, and that can show in our behaviour, in our facial emotional detachment can result, and therefore the clinician-patient relationship is perhaps fractured. So if we think then about the effective empathy required in empathising with a suicidal wish, we can see the value of it, we can see the importance of it, but of course there are drawbacks. And these drawbacks include things like empathic distress, which has been touched on earlier on, and in the emotional contagion where the self-other distinction becomes lost. But also, I don't know if there's such a thing as empathic confusion, but I feel that there is, because I think, as clinicians, we see lots of patients. If on my clinical days, I might work in A&E, and it might be 12-hour shift, and it will be a 12-hour shift, and in that shift, I might see a number of patients who come in with suicidal thoughts, suicidal behaviours, suicidal attempts. So for me, when I think about empathic confusion, it's whose story am I in? Whose feelings am I feeling? Where am I lost? And so I think that it is something that we should perhaps contemplate. But there's also the lack of empathic capacity potentially, in that whether that's to do with the burnout that we've already heard about, or whether it's to do with if effective resonance is required for effective empathy. And the stories we hear and the trauma that the patients we work with have been through, the things that have happened with them, have we got the reserves there to be able to do that, to sit empathically with it? So I think these are all the potential drawbacks of effective empathy if we over-rely on that dimension of empathy. So the other important part, and that can lead to empathic disconnection, which I'll talk about later. So then the other side of it, of course, is the cognitive empathy, as we've already heard. And in relation to suicidality, this might be where we focus on understanding the patient's suicidal idea rather than effectively resonating with it. And that might be underpinned by drawing on psychological models and empirical evidence and our own clinical experience. So that sounds really good. But then if we are over-reliant on cognitive empathy without the effective component, then we risk becoming overly distant and perpetuate the us-them dichotomy. And obviously that's very different from the self-other distinction. It's the power imbalance of the clinician-patient relationship that can sadly shut people down if it's too present. So maybe then, or some people have said, well, okay, what about motivational empathy? That's a pretty good thing. It's linked to compassion. It's underpinned by benevolence. It's linked to the motivation for empathic action. So which sounds great, but then I think there are downsides of that as well, which is that we might go into fix-it mode, which will also shut that down. And I think we're quite good at that sometimes. Certainly nurses are quite good at that. So what do we need to do then to try and effectively work with our patients who struggle with suicidal thoughts and behaviours? It's about getting the balance between the effective and cognitive empathy, realising both, but staying safe within that sort of milieu. So for me, this is where empathic validation comes in, that Bryony's already talked about. So empathic validation has this shared understanding underpinned by compassion that draws on that affective sense, but also cognitive empathy. And I've drawn on the work, I can't pronounce his name, Tietbol, to sort of help me really think about empathic validation. And their work was with physicians who were largely working with older adult populations, so it wasn't in the context of suicidality. But the good things about this is that it's not reliant on the empathic opportunities within a patient's narrative, the expression of emotion, the self-identification of emotion that we can then come into. But actually, it allows us as clinicians to use our own intuition to pick up perhaps body language or a sense and focus on that. And it can be helpful, it's said, when there are no medical solutions, which for me is really good when we're thinking about suicide, because we can modify certain aspects of with somebody that might alleviate their suicidality, but we can't predict suicide, and we're not magic. And so it helps us sort of work within those limitations. So the key characteristics around normalization, and of course, we cannot normalize suicide, and it's not thinking about that, but what we can normalize, if we think about what empathizing with a suicidal wish is all about, is we can normalize psychological pain in response to trauma or loss or defeat or whatever the person has been through, and acknowledge those individual difficulties and recognize choices to enable us to work with them. So it does seem to be a sensible and perhaps safer way in than either the extremes of cognitive or effective empathy alone. However, it's only ever going to be effective if it's authentic, and that means full presence. So it's all well and good me thinking this, but I've spent some time talking to some of my lived experience colleagues to ask them. So I am going to just read this so I sort the time out. So this is Julie, and I asked her perspectives, and she said, I don't need someone to empathise with my suicidal wish, but instead express understanding of the pain of my wish. Validation tells me that you see my pain, you see how unrelenting and unbearable it is, you see what a great struggle it is for me to stay alive in this moment and in all the moments leading up to this one. Validation tells me how glad you are that I'm actively seeking support and that you genuinely care whether I live or die, that I matter, that my life matters, with no attempt to talk me out of my feelings or fix them. And until I feel truly heard and seen by you, I will not be able to hear anything you advise me, and launching into problem solving too soon is a sure way to shut me down and increase my feelings of disconnection. So that really fits with the whole principle of empathizing with a suicidal wish, and it fits to me with empathic validation. So for an example in practice then, so this was working with somebody who came into the A&E department and was very stuck and very fixed on that suicidal wish, and was only able to sort of articulate that and articulate very little else at this point in time. So the effective thing for me was around understanding that this person needed me to understand the seriousness of what was going on for them, and that this was really big and just colossal, and I needed to understand that somehow. So it was a safe emotional resonance for me, because it was understanding the need as opposed to getting lost in that sort of suicidal place. So for me, I love Schneidman, and I often use his work in my practice. So I drew on principles of psychological pain and the need to escape as a solution, and feeling constricted and seeing suicide as the only way out, and shared my understanding curiously and sensitively with the person. To sort of convey that understanding of what might be going on. That's the normalization bit of empathic validation. And then I brought it to them and sort of put my understanding of what I know into what might be going on for this person, and we had this sort of conversation about what it might mean for them, and might that be how it was for them. And so by tailoring it to that person and their story and their context, it enabled me to sort of move on then to complete the full biopsychosocial assessment that I needed to do. And the relief at the beginning by doing that, the relief was palpable. I could just see it. I could see that person relax a little bit. And that's what enabled me to carry on and do that wider assessment. So I feel it's an effective way to work with people. Now, extending empathy to family and carers, I think, is so important, because we often think about the patient, but the realities of mental health care is that we all rely massively on families. And so I think we do our best often to involve families and work with families and inform families, but we do need to ask ourselves a question as to whether or not we empathise with families. I mean, this is a really strong statement that comes from Costello's research. But it's kind of really quite painful even to read. This is how family members are sometimes left feeling. And it led me to think, why do we not empathise with the family and carers' experience? We might give some leaflets, we might give some information, we might say, here's a safety plan, but do we empathise? And I think we don't really understand the experiences of families very often, which was why my research was in this area. And I'm not going to bore you with 7 years of study, but just briefly, what seems to happen with family members and carers is that there's so much uncertainty. So linking with the uncertainty in illness model, when people are thrown into having a family member who's suicidal, they're unfamiliar with that, they're terrified, they've got these hot cognitions going on, they're not able to sort of weigh things up as they ordinarily would. They've understandably then got this powerful other sense of locus of control. Oh, good, you're here, you're going to help, you're going to cure this person's suicidality. Thank goodness that's all going to be okay. Obviously, their uncertainty is appraised as danger. As time goes on in the trajectory of perhaps of repeated cycles, people's ways of coping change. They may start as hypervigilance because of that danger appraisal, which might have detrimental effects within relationships. And as time goes on, they might tolerate uncertainty and learn different ways to cope. And the information at the bottom is something that people need all the way, but they need to be given it in the context of empathy. It's no good just giving these leaflets. So if we use the principles then of empathic validation with family members, we can, if we understand why somebody may have a powerful other's locus of control because of those danger appraisals, we can validate that and we can work with it. Similarly, if the internal locus of control is becoming hypervigilant, we can understand it, work with it, and so on. So we do need to extend our attempts at empathy to family members and friends. But it's not always easy, and empathic disconnection is something that we really do need to think about, where our empathic function is sort of reduced, whether that's conscious or otherwise. And that might be empathic distress or emotional contagion, but it might be some of these other things: countertransference, hate, moral judgment, reactive physical discomfort, and labelling, which are obviously all linked. So we talked a bit about countertransference and transference, Brownie did. And countertransference hate was coined sort of in the 70s by psychoanalysts, actually, who observed that in practice, people's countertransference reactions to suicidal patients were often quite negative, and they used the words aversion and malice. So they said that clinicians felt aversive or they felt malice towards their patients when there was a suicidal state. So they called it countertransference hate. And they say that obviously this countertransference is underpinned by various things, whether it's patient's transference, our past history, professional history. But they also talk about the narcissistic snares that we carry with us as clinicians of heal all, love all, know all. And that when they're thwarted, because we can't get suicidal patients better, we fall into the trap of this countertransference hate and the other things that you can see listed here. So I want to just share Linda's experience, who's another lived experience colleague. And she shared a story of phoning her team, spoke to a clinician to say that she was struggling. I haven't put the whole story in there, but anyway, she was struggling at home, Linda. She was experiencing thoughts of self-harm. She was thinking about ending her life. She had a long background of repeated self-harm, lots of suicidal crises. She had a diagnosis of emotionally unstable personality disorder. She phoned her team, and her response was this, very nice, pleasant practitioner, but conveyed that they weren't really that concerned about her. She needed to, take responsibility for herself and practice the coping strategies that they talked about. And Linda subsequently felt very unheard and rejected, and she went on to self-harm. So if we think about this sort of scenario, which happens all the time in mental health care, there may well be factors going on that sort of, suggest presence of countertransference hate, in that perhaps the clinician was just desperate to get off the phone because they were thinking, oh gosh, it's her again, what am I going to do? I don't know what to say anything that's going to do anything. you know, there might be some labeling going on, because there is a big labeling issue around repeat self-harm and personality disorders. So maybe that led also to wanting to put the phone down. But it might also be that fear. I do not want to be the last person that speaks to Linda before she goes on to end her life. So I'm actually just not going to have the conversation. But whatever it is, it's empathic disconnection that's going on. So how do we deal with empathic disconnection? Hang on. So I think we've got these strategies here of self-empathy, self-compassion, and self-reflection. And the reason that I've come to sort of really believe in this is through my own experience. And the first one, I'm going to share the more recent one, really, because this is only the last few years of my career. I've been nursing for over 30 years. So, I'm fairly long in the tooth, and I've learned ways of coping. So this was about, I was working with a family member who had lost somebody to suicide, bereaved family member. I haven't been bereaved by suicide myself, so I practice in my work the concept of empathic validation, because it enables me to work effectively with someone even though I don't have the experience. Now, whilst I was working with this person, I was also at home looking after a member of my own family who has quite significant mental health issues and was struggling very much at the time, although not with suicidality. And I really identified with this woman for various reasons, mainly the similarities between the person who died and my family member, and also her as the her role, the bereaved person, was her role in the family. And I liked her as well. But anyway, I kind of got very blurred. So I think this was the emotional contagion. I kept thinking about this family all of the time, and I was really preoccupied with it. I was dreaming about it, I wasn't sleeping. I was constantly thinking about it. And then I was going home and I was becoming really vigilant with my family member for no reason. Suicide wasn't an issue. And I don't know why, but I became very vigilant. And so I got myself in a real state where I couldn't work effectively with this family member. Excuse me. Nerves. And I wasn't really supporting my family member in the way that I wanted to do. So self-empathy, self-compassion, self-reflection, in no particular order, really helped me with this. So I felt so uncomfortable and distressed, I had to think about it, a bit of reflection. With the self-empathy, I was really able to kind of name and understand and accept some of the emotions I was feeling. So I felt very guilty. I felt guilty that I was preoccupied and not able to be present for this family member because of my own family member. And then I felt guilty because, she's alive and she isn't alive. What's going on here? And then I felt helpless because I thought, well, I can't do anything for this family member. And I felt helpless because I can't do very much for my family member, or I couldn't at the time to change things. And then I felt very frightened because I was frightened that my family member would end their life. And so I was getting in a real mix. But at least it helped me understand them and sort of sit with those feelings that I had. Self-compassion, which is about kindness and common humanity, helped me be kind to myself and say, it's okay and it's understandable. And you're probably not the only one that has felt this way because of what's going on in your own life. And then the self-reflection enabled me to take that forward and really work through it, look at, increase my self-awareness, think about strategies, work out ways of being present, but contained, and so on and so forth. So I managed to do this on my own. It's quite a private thing for me at the time. And I did this on my own because I had that experience as a fairly old nurse. But there's another experience I had very early on in my career as I was a new staff nurse working on a ward. There was a patient, tell me if I'm running out of time because I can't see the clock. I'm nearly done. There was a patient who had pervasive suicidal ideation. And I remember vividly, even now, I remember the physical feeling I had in my stomach when I would have to talk to this lady. It was all kind of flight response. I felt helpless because I didn't know what to say. I was dreading her talking to me about her suicidal thoughts. I thought, I don't know what to say. I felt I had to cure her. And I thought, well, I can't. And so I felt inadequate and I felt helpless. I was desperate to get away, felt deeply shameful that I did. But if anyone did call me away for another task, I really felt massively relieved. And that had a big impact on me. And I thought, gosh, I cannot do this job. I felt inadequate and, as I say, ashamed. So I talked to my clinical supervisor about it. I was very open about the feelings. And the empathy that I received from her was really instrumental in my subsequent professional growth. So that, it is said that to truly empathize with others, you must be able to empathize with yourself. To empathize with yourself, you need to experience empathy from another. So there's this kind of like connection. So for me, that's empathy I had from my clinical supervisor sort of emancipated me from this burden of strong emotions and shame, and enabled me to then reflect and learn more about myself and learn this sort of self-compassion that I'm probably not the only one here. I have limitations personally, I have limitations professionally, and I am fallible. And that was really fundamental, I think, for me to be able to develop, professionally and to gain wisdom. So it's a very poor diagram. I'm not very good at diagrams, but I think empathic disconnection is going to happen to all of us at some point. It's a reality. And that might be feelings, it results from and in feelings towards ourselves and feelings towards our patients that might be very uncomfortable. And if we don't address them, our empathic ability is going to be severely compromised. So by drawing on these concepts of self-empathy, self-compassion, and self-reflection, we can really transcend those difficulties. But clinical supervision and reflective practice is key. So I think what the lady was talking about before about regulating empathy, supervision and reflective practice are essential really for that, to help us improve patient care but maintain our own well-being. So in summary, I do believe that empathy is a core skill when we're working with patients and families in the context of suicidality. And effective and cognitive empathy are both required, but the extremes of each can be problematic. So empathic validation offers that balanced approach, clinical utility, and preservation, if you like, of our own well-being. And we will encounter empathic disconnection. And I think we need to be open and honest about that in order to prepare the younger generation of clinicians to the reality that they will too. And we're only going to really do that by sharing and by effective clinical supervision and reflective practice. So hopefully I haven't overrun too much. Thank you very much.